actually a very, very one of my favorite topics as well. It's a very interesting topic. It's a topic that I would say doesn't require it's too much heavy memorization. It doesn't require also a lot of heavy thinking as well. So it's definitely a lot, I would say, easier than diabetes. It's definitely not diabetes. But it's something that gives a practical overview of how community pharmacy works in Canada. So I know some of you may not be from, of course, may not be joining us from Canada, from anywhere, somewhere in Canada. Maybe you were joining us from overseas or internationally. So this lecture is kind of here to give you guys an overview of how community pharmacy works in Canada. For those of you who are in Canada, what I highly suggest you do is if you can try to get some sort of pharmacy experience here. So even if it's not like, for example, like a pharmacy assistant job, or just to get an outlook of how a pharmacy system works in Canada, you can try to even volunteer if you have the time, and if you're okay with volunteering, try to find a community pharmacy near you and just ask them if you can volunteer, because I personally think that just getting that experience here will really help you on the exam, because you'll kind of make links and then you'll remember, and you'll be able to use the knowledge and experience that you have to answer questions on the exam, whether for EE or MCQ. Okay, I really think it'll help you also for the MCQ. So this lecture will give you an overview, but I think experience is also going to help you. So if you can try to get some experience, then this is going to be very beneficial for you. So Wisdom is asking, do they allow volunteers as pharmacists, or do we volunteer as a pharmacy assistant? So in Canada, you cannot volunteer as a pharmacist, because to be a pharmacist, you have to be licensed. So you'd be volunteering as a pharmacy assistant first. Once you get licensed, then you'd be a pharmacist. Okay, so just some background information here is we are going to kind of talk about throughout the lecture all of the different scenarios that you may encounter in a community pharmacy. Okay, so we're going to be understanding how the community practice and works here, and then as well how to navigate some of the gray areas. So what I mean by gray areas is usually you're not going to get a black or white answer. It's not going to be something that's straight out of a textbook. Scenarios, they may be a little more on the gray area. So it's like you'll be confused. So what would you do? So that's why we're in the lecture, we're going to have some cases so we can discuss some of this. Okay, so understanding community pharmacy. Community pharmacists, as you guys might know, you might have experience from back home. Community pharmacists are the most accessible healthcare professionals. And what they mean by that is we are easily reachable. Why? Because you can just come to the pharmacy and then you can speak to a pharmacist. They can help you pretty much on the spot. And what a community pharmacist does is that they supply medicines in accordance with a prescription. So we can dispense prescriptions. Of course, we have to look at the legal aspect, and then we can sell certain medications without a prescription. So these would be over-the-counter items, and I'll tell you what that means shortly. Over-the-counter. So this stands for OTC, over-the-counter items. So in addition to ensuring an accurate supply of appropriate products, their professional activities also cover, so we also counsel patients. So we explain how the medication works. And this is called counseling. So how the medication works, what the medication does, and side effects. That's part of counseling. So we explain counseling as we're dispensing a prescription, and also when we're giving over-the-counter non-prescription drugs. Because over-the-counter drugs, we still have to explain to the patient how to use it, right? That's also important. And then sometimes patients might come up to us and just ask us regular questions. So we provide drug information questions. So that's where we fit in. We can help patients and the general public from there. Okay. We also participate in health promotion programs. So health promotion, think about it as we are promoting vaccinations. That's just an example. There's many health promotions, but promoting vaccines such as flu shots, COVID shots, shingles vaccines, things like that. And then what we also do is that we maintain links with other healthcare professionals in the primary healthcare. So what that means is that we, in addition to doing all these activities, we also have to stay in contact with the prescriber, so the doctor or the nurse or whoever it is that's working within our field, okay, that is providing care for our patients. Okay? Okay. So when it comes to community pharmacy services, we have to look at four different aspects here. So product acquisition. So this is where we obtain the product, or when we buy the medication, like as pharmacy owners or pharmacists buy the product. So product acquisition. Storage is where we store the product. So where do we keep it? Do we keep it in the fridge or on the counter or at room temperature? Dispensing process. So this is when we're giving out the medication. And then we look at the follow-up aspect as well. So this is when patients require follow-up, when we dispense a medication, and then perhaps we follow up with them in a couple of days to see how well the medication is working for them, as an example. So product acquisition is what we're starting off with here. And what that means is we're getting or buying the product. So we are acquiring the product. And usually with product acquisition, we want to make sure that the distributor, so McKesson is one of the like distributors. Okay, so it's a wholesale that distributes medications. So I'll explain that a little further. So as we acquire, as the drug company, for example, the drug company that makes the product, as they approve the product, of course, Health Canada has to approve it, and then it goes on the market. What happens is us pharmacies, we get the medication. We don't necessarily get it straight from the manufacturer, but we get it from like another distribution center, which is one example is McKesson. Another example is also KNF. But you don't need to necessarily need to know the examples. Once you work in a pharmacy, you'll be able to know what those examples are. So MCK stands for McKesson. This is one of the distributors. So what they get their medications from the manufacturer, and then we buy or we obtain the medications from the distributor. So it's not the manufacturer. Some cases we might, but very rarely we get it from McKesson in particular, or a distributor. And what we look for is, when we're looking for a distributor, we have to make sure that they have a stable, rapid, and secure product delivery. So like we have to make sure that their products are secured when they're delivered to us, and we have to make sure that the supply is stable. What's the point of picking a distributor that always runs out of medications, right? And then what we need to look into here as well, sometimes we can have barriers. So those barriers would be back orders. So what does back order mean? So back order is when the medication is not available. We don't know. Sometimes we may know when it becomes available. Sometimes we may not. So sometimes they tell us it'll become available in 2 weeks or whatever. Okay? And then we can also have recalls. So recalls is when the drug manufacturer takes the product off the shelves or off the pharmacy And recalls usually occur due to many different things. So one of them would be, let's say, a contamination. Okay, so as an example, there was a medication for acid reduction called ranitidine, which was deemed to have a contamination of carcinogenic products in it, or substances. So they recalled it, they removed it from the market or the shelves, and then they issued a statement. So that's what a recall would be. Okay. Some other barriers would be counterfeit drugs. So counterfeit meaning like drugs that are not approved by like Health Canada, and they're just kind of getting them from like the black market or something. And then of course cost is another barrier to getting the product. Okay. You can either buy the product independently, so like through the manufacturer, or through like buying groups. So you might ask and say, what is a buying group? So a buying group, what it does is that it takes multiple independently owned pharmacies and it puts them in the group. So literally a buying group, to take it from the word. So it puts them in the group, and then they take their entire business, so all of these groups, and they bring them to like this negotiation table. So they negotiate with them. Whichever group that offers the best cost of goods, or like the best cost of or the best discount, I guess you can say, gets a like a contract from all the pharmacies. And then once they provide that amount, and it's an actual, I guess you can say, it's a reasonable number for all the pharmacies at the negotiation table, then they come up with a contract, and then they get some sort of discount, because now it's multiple pharmacies coming together. Okay? So that's what would a buying group mean. I hope that made sense. Okay. When it comes to the medication supply chain here in Canada, we look at really the basics. So drug manufacturer, as I mentioned, they submit research on a new drug product, and they submit this to Health Canada. So that's step number one. Of course, Health Canada has to approve this, and they look at different aspects. So they look at the safety of the product, the efficacy, so how well the product works, and the quality of the product. So how good is the product overall? Once the approval comes into play, what happens then is that there is a lot of factors that get added up. So federally, provincially, and territorial agencies, what they do is that they manage drug prices of each drug. And then what they'll do is they're going to have this review. They're going to conduct a review to decide if this new medication is worth it. So is this medication worth it to become covered in the public drug plan, and under what terms? So for example, what these agencies do is that they look at, first of all, they'll look at how well the medication works. They'll compare it to whatever is on the market currently. Okay, so if they see that there's a drug on the market that's just like it with a very cheap price, then what's the point of including this new drug that came out into the formulary of the provinces? So why would the government or the provinces cover for this new drug if there's already a good drug out there, right? So they do this comparison, they do research, they look at the price, they look at how well the medication is, in terms of efficacy, safety, things like that. But they focus a lot on price. Whereas Health Canada, of course, has to focus on safety, efficacy, quality, things like that. These agencies, they look mostly at price, and they conduct a review, and they kind of compare the different drugs that are out there. And then finally they see, okay, this drug is worth it to be included in the government plan, so that the government pays for it. I hope that makes sense. So once the drug, of course, is approved and everything, then what happens is the pharmaceutical company So this is what I was mentioning in the previous slide. They use distributors. So I gave you an example of McKesson Canada, and then there's another one, the Canadian Pharmaceutical Distribution Network. I mentioned KNF as another one. So there's a lot out there, okay? And what they do is they distribute the medication in bulk to the pharmacies, as opposed to the pharmacies getting it from the pharmaceutical company, okay? Finally, what happens then is that us healthcare professionals, so if it's a doctor, they're going to prescribe or deliver. If it's us, we can dispense medication as pharmacists and administer these medications to the patient. Okay? So I hope that made sense. Okay. So I just want to answer a couple of questions here very quickly. Do wholesalers give pharmacies the same prices as manufacturers? So this is what I was mentioning with a buying group. The more pharmacies that are involved in the buying group, the bigger the discount. Okay, so that's why it's much better to be in a buying group, because then you'll have a better discount overall. Okay, Mujahid, I hope that made sense. I hope I answered your question. And then Jayasri wants me to repeat recall. So basically, recall has to do when the manufacturer takes the product off the shelf. So the manufacturer says this product was contaminated with something, for example, with a carcinogen or some substance. So we have to take it off the market or off the shelves for now. And then they, just for a particular batch. So they might not take off each and every single batch. It's maybe whatever has been affected. Okay? I hope that made sense. All right. So NAPRA is the National Association for the regulatory bodies for pharmacy. So this is a national entity or national body. What they do is that their main purpose is to serve the membership or its members and act as a resource for the public by giving them information and guidance on pharmacy regulation in Canada. So NAPRA is responsible for your exam. They're the ones that come up with all the different aspects of the exam that pharmacists have to write in Canada. Okay? So they look at really national model standards, and they look at guidelines. As again, this is all nationally. What they do also is they try to nationally, so all over Canada, they try to harmonize the practice of pharmacy. So across the entire country, so across all jurisdictions, which is like across all the provinces, basically. And so this is to make sure that you're having a consistent level of pharmacy care for patients all over the country. Okay, so I hope that makes sense what NAPRA does. I would know NAPRA. NAPRA is important. I think that can easily come up on the exam. And then what they do is they kind of have conversations with the federal and other domestic and international government agencies. And this is to have health-related professional organizations come together, of course, on behalf of the Canadian pharmacy authorities, and just kind of have an overall, I guess you could say, body that can represent Canada in a way, if that makes sense. They also give programs such as what we call the National Drug Schedule. And they have also the Pharmacist Gateway Canada. So we'll go into this here. But I just want to make sure that you guys know what national drug schedules are. And this is where we're going to get into it. But this is where each medication So whether it's over the counter, whether it's a prescription, it gets divided up into its own schedule or own group. So I'll tell you what that means a little further. Okay, and then NAPRA finally provides this platform. So it provides this entity or this body to discuss common issues affecting pharmacy practice in Canada. Okay. So this is the National Drug Schedule. So we're looking here into storage. Now we've talked about the product acquisition. We talked about how the product gets bought or brought to the pharmacy. Now we're going to talk how the medication gets stored in the pharmacy. And this is where the National Drug Schedules come into play. So remember I was saying each medication is going to get divided up into its own group or own schedule. And so there is 4 different types of schedules. There is Schedule 1, Schedule 2, Schedule 3, and then you can say unscheduled. So it has no schedule, basically. So 4 categories in total, or 4 groups. And the reason why we have national drug schedules, like what is the purpose of putting medications in each schedule? And that is because we want to establish the condition for sale of products. Okay, so which ultimately guides the level of professional intervention. So depending on which level my drug is in, so if it's Schedule 1 or Schedule 2 or Schedule 3, I may need a pharmacist to give out medications in Schedule 1 or 2 or 3 or unscheduled. So depending on which schedule the medication is in, this determines the level of intervention by the pharmacist, okay? And that's to provide safe and effective use of drugs. Well, we're going to get some examples shortly. And of course, finally, NAPRA's main purpose is to serve its membership and to act as a resource for the public by providing information and guidance on pharmacy regulation in Canada. Okay, so it's all about regulations. So if you had to take anything away from what NAPRA is first of all, it's national, so it's all over Canada. And it deals with the regulations. So I always like to divide up the words so that you understand it better, and I highly suggest you do the same. So it's all over Canada, it's national, and then it deals with the regulations of pharmacy. So now we're going to get into a little more about examples of national drug schedules. So I mentioned that each drug gets put or divided into its group or into its schedule. So what does that mean? Schedule number 1 here. Whenever you hear the word, so medications that are Schedule number 1, means that they are in Schedule 1, which require a prescription in order for us to dispense that medication. So I'll give you an example. Percocet. So Percocet is a medication that requires a prescription in order for me as the pharmacist to give it out to patients. If I don't have a prescription, a patient can't come to me and says, hey, Rima, can I get 5 tablets of Percocet? It doesn't work that way. So it needs a prescription from the provider. And it's not available, as I mentioned, for self-retrieval. So it's not like the patient can come, grab it off the counter, and then take it, buy it and take it with them. It doesn't work that way. It needs a prescription. Okay, so that's example number 1, which is Schedule 1. Schedule 2 does not require a prescription. Prescription is not required for sale. However, it is also not available for self-retrieval. So what that means is the medication gets put somewhere closer to the pharmacist. So it would be behind the counter. So there is over the counter, which is across from the pharmacy, and then there is behind the counter, which is behind the pharmacy. So usually Schedule 2 products are kept behind the counter. And this is because you need, for Schedule 2 products, you need an actual pharmacist. In order for you to buy it, the pharmacist has to give it to you and explain it to you. So it's not enough that you can buy it without a prescription. The pharmacist actually has to give it to you and explain it to you. That's why it's in Schedule number 2. Okay, example of this can be insulin products. All right, that's just one example. I think someone said, Prashi said, like Ferromax, exactly. Like it's things that are kept behind the counter. Schedule 3 here is prescription, again, not required for sale. However, this time you can buy it on your own. So you can buy it over the counter. So this is what I was mentioning, OTC or over the counter. Pharmacist still has to be in the pharmacy, but you don't have to bring it to the pharmacist to explain it to you. They can just buy it. It's fine. Okay. Examples of this would be like Tylenol, 500 milligrams, things like that. Just Tylenol on its own. Things like that. That would be an example. Okay. Unscheduled products would be products or prescription that's not required, again, for sale, and then you can buy it for self-retrieval without a pharmacist. So unscheduled would be like buying something in any retail outlet. So sometimes, I don't know if you guys have seen, but sometimes in gas stations, you may see like a small pack size of Tylenol or a small pack size of Advil. This is an example of unscheduled. So it's in any retail setting where a pharmacist is not even present. The pharmacist is not even there. So without pharmacist supervision. So that would be like something you pick up as an example at a gas station. Or Mary said in Dollarama. Exactly. That's perfect. That's another great example. Okay. Now, when we're looking here at the restrictions of how restricted the items are, we look at the arrow here. So highest would be going from Schedule 1 to Schedule 2. This is the most restricted access here. And then over here, it's the least restricted access. So it's not as restricted. Okay, so this is what the arrow means. Okay, so I wanted here to provide a little bit of like a picture for you guys as to how a pharmacy looks like in Canada, in case you don't have experience here. So normally, this is the outlook. So you'll have a pharmacy, there's shelves over here, shelves over here. This is where medications that are Schedule 3 are kept. So anything purple, so let me come on this side. Anything purple, and so right over here, would be Schedule number 3. So this is like your Tylenol here, your natural health products. So they would be here, basically. They're located within 10 meters or 30 feet of the dispensary. So the dispensary itself would be like things that are behind the counter or the actual pharmacy itself, pharmacy counter. That would be Schedule 3. 10 meters within the pharmacy or dispensary. You'll see here that you have a private consultation room. So this is where we normally do our vaccines, or if a patient wants to speak to us privately, so we take them there. This is a room where there's some privacy. Okay. You'll notice now here we're at the dispensary. So the dispensary is going to have a drop-off portion. So this is where you come and you drop off the prescription. Okay, so you give the prescription to whoever's there to process the prescription. The prescription gets processed. Once you come to pick it up, you come at the pickup area and then you pick up the medication there. Schedule 2 products is, I was mentioning, things that are behind the counter. So behind the counter is anything that's Schedule 2, and we said it requires pharmacist intervention. So this would be here. So this would be something over here. That would be Schedule 2. Schedule 1 is products that are, we said, that require prescription, and they are kept somewhere like in the back of the dispensary. Of course, narcotics are kept in the safe. And so this would be the outlook of how a pharmacy looks like here. So I hope that kind of gave a visual. Okay. So I mentioned that narcotics require a safe. And the reason for this is because there's been a lot of theft that's been taking place in pharmacies Canadian-wide. That's why there's now specific or special storage requirements. So I'm lecturing from Ontario. This is found throughout the provinces as well. And what we call this special safe called a delayed safe. And the purpose of delayed safe is what it does is you enter your code in the safe. So each pharmacist will have their own code. You'll enter the code. You have to wait 5 minutes for the safe to get activated. Once the safe gets activated, you have to enter your code again. And then it opens. So this is a huge shift from the previous safes where you had just a key. So it's a huge shift. And the reason why a lot of pharmacies are adapting this is because it's supposed to help with in case there's robberies. So in case you have a robbery coming or there's someone trying to rob the pharmacy, then you tell them that I have a delayed safe. So delayed safe means it takes 5 minutes. Takes 5 minutes for the safe to open. So usually thieves don't want to wait that long for 5 minutes because by that time someone may have already called the police and the police would have come. So they don't want to wait for 5 minutes. So what they do is if they see a pharmacy, that's why we put up signs in our pharmacies. We have delayed safe. So when they come, they see delayed safe, they're like, oh, never mind. Okay, I'm not going to rob this pharmacy today. It's fine. They have a delayed safe. Okay, so it's supposed to help in that situation. Okay, how effective it is, we're finding out. We're finding out. Okay. So now we're talking about the narcotic and controlled products. Okay. So when it comes to narcotic and controlled products, we have what I've done here is, you'll notice I've kind of changed around some things on the slides. And I tried to make it as easy as possible for you guys to understand and to memorize or to remember. So controlled substances include narcotics, controlled products, and benzodiazepines and targeted substances. Okay. So we'll start off with narcotics. So we divided them up into narcotic drugs and narcotic preparations. So narcotic drugs are products with only one straight narcotic. Okay? So straight narcotic, which would be heroin, hydrocodone, methadone, oxycodone, pentazocine. So products would be containing all of these. There are also narcotics that are used parenterally. those can be counted as a narcotic. And products that have more than one narcotic in them as well. That's another way of saying this is a narcotic drug. As well as narcotics with less than 2 other non-narcotic ingredients. So if I have a narcotic with less than 2 non-narcotic ingredients, then this is still considered a straight narcotic. We're going to do some examples. I know this is a little confusing, so we'll do some examples. Narcotic preparations contain only one narcotic, which exclude the 5 that are listed here. So it's one narcotic, but it doesn't include these 5 products. So it excludes the 5 listed as part of the drugs. So not only does it contain one narcotic, but it also has 2 or more non-narcotic ingredients. And then again, we'll do some example there. Anything that we can take verbally as a verbal prescription, we call it also as a verbal narcotic. Within the preparation, there's also what we call exempted codeine preparations. And what this is basically you have to have in the exempted product 8 milligrams of solid by mouth dosage of codeine. Okay, either 8 milligrams of codeine or 20 milligrams over 30 mils of liquid. Okay, plus 2 or more non-narcotic ingredients. So in order for us to have an exempted codeine preparation, the medication has to have up to 8 milligrams worth of codeine, if it's an actual tablet, or 20 milligram over 30 mils of liquid, and 2 or more active non-narcotic ingredients. Okay, this would be the narcotics. So like I said, we get divided up. I know it can be a little confusing between what a controlled substance is versus controlled products versus controlled drugs. Controlled substances, think about it as the big umbrella, and it looks at these 3 different categories. Okay? So that would be an example. So again, going back, narcotic, if we looked at narcotic drugs, so these would be your straight narcotics, and they would have one of these 5s as well. Okay, so heroin, hydrocodone, methadone, oxycodone, or pentazocine. Okay, other examples would be like, of course, codeine. But whereas preparations would be more of like Tylenol 2, Tylenol 3, and then I'll give you guys an example as to why we put them in that category. And the next slide. Controlled drugs here. So now we're on category number 2. Controlled drugs are divided into 3 parts. Part 1, Part 2, Part 3. Part 1 looks at, it's under Part 1 of Schedule, of the schedule to Part G of the FDA. So I don't know if you guys have had your federal lecture yet, but basically under Part G of the Food Drug Act, so FDA is the Food Drug Act, under Part G, Part 1 controlled drugs are listed there. So basically all of the controlled products are under Part G of the FDA. Okay, all controlled drugs. So part 1 of the drug says products that contain only one or more than one controlled drug. So what does that mean? So either examples would be amphetamine or methylphenidate. So this would be something like your ADHD medications. Preparations of these would be one controlled drug plus one or more non-controlled ingredients. So I want you guys to understand that with preparation, with any of the preparations, okay, they have non-controlled ingredients as well. So we saw here non-controlled narcotics here, and then over here for the controlled part, we have we have one or more non-controlled ingredients. So the preparations will always have non-controlled ingredients. So maybe that will help you remember it better. Okay, part 2. Again, we said it's part of part G of the FDA. Part 2 includes phenobarbs and barbiturates. That would be part 2. The preparations would be one controlled drug plus one or more non-controlled ingredients. Okay? So an example of this would be Technol, as an example. I think something like this will definitely come up in like a federal exam or like a provincial exam that you guys might have. Some of it does come in the MCQ, and it will probably also come in on the EE as well. So I would know these. Part 3 looks at testosterone. So it's anabolic steroids, anything to do with testosterone. That would be part 3. Preparations, you basically don't need to know because they're not even available in Canada for part 3. Okay. Lastly, we have the benzodiazepines and targeted substances. So you have alprazolam or lorazepam, things like that. And these are basically a little less restricted than the rest, but you still want to look out for them because they can still cause that addiction aspect. So this would be the controlled substances umbrella. Whenever you hear the word controlled substances, you have to remember that this is the narcotic and controlled products. Okay? So I'm getting some questions here about if you guys will have these types of questions on your exam. I think you might, just because for sure MCQ you will, but on the EE, this is not provincial. Remember, this is federal because this is part of NAPRA. Okay. So this is also like, this is provincial, provinces will, of course, when you do your actual exam, and you pass, and then there's going to be a jurisdiction exam as well. So on the exam for jurisdictions, there's going to be a law exam. This will mostly get tested on, but I think on your actual EE and MCQ, they can still technically test little stuff about this. Okay, so I would still know it. So we're going to get into some examples of these. I do want to mention that this is actually, so this particular stuff about the storage and narcotic control products are actually covered in your federal lecture. So the reason why I didn't go too much into details, because this is all in your federal lecture. I'm not sure, have you guys had it yet or not? So not yet. Okay, so this is in the federal lecture. So I would look out for this also in your federal lecture. They go into a lot of details with this as well. But I want to give you guys an overview in terms of narcotic storage, because again, remember, this is our community pharmacy lecture. Okay, so let's have a look at this over here. I hope this this exercise will help you a little bit differentiate between what's a narcotic drug versus what's a narcotic preparation. Okay, so take a few moments and look at these four different products, and if you guys can, I want you to read the actual, if you can, if it's clear for you, read the actual products. Okay, if you can't read it, then just Google it. So this would be Tylenol 1, Tylenol 2, Tylenol 3, and Tylenol 4. Read the products, see the ingredients, and then tell me what the difference is between each product. What do you guys think? Okay, I'm getting a lot of people saying codeine. Exactly. That's perfect. Perfect. Exactly. The codeine amount in each. Okay. So Tylenol number 1 has 8 milligrams of codeine. Okay. Tylenol number 2 has 15 milligrams of codeine. So we said Tylenol number 1, the reason why it's called Tylenol number 1 is basically it has acetaminophen, which is Tylenol. Okay. It has caffeine. And it has codeine. Okay. All the other products, the same. So all of them have Tylenol, so they have acetaminophen, they have caffeine, and they have codeine. And they all have 300 milligrams of Tylenol or acetaminophen, 15 milligrams of caffeine. Where they differ is the codeine. So Tylenol number 1 has 8 milligrams of codeine. Tylenol number 2 has 15 milligrams of codeine. Tylenol number 3 has 30 milligrams of codeine. And then Tylenol number 4 is 60. Does that make sense, guys? So the quantity of codeine is where they differ. And I just want to mention here, so the acetaminophen, caffeine, and codeine apply to these three. However, Tylenol number 4 is an exception. It has no caffeine. Okay? So if you look at the previous slide of what I mentioned, okay, I said in the previous slide that I showed you guys the differences between the drug classes. So you got this question perfectly. So this is the difference. Now, can you tell me for question number 2, what is the drug schedule of each drug? So I see lots of great answers. I see really good answers, okay? So they are all Schedule 1, except which one? Exactly, Tylenol 1. Tylenol 1 is Schedule 2. Okay, so this is where NAPRA comes in. And Tylenol number 1, a lot of you guys are saying it's BTC or behind the counter. So Tylenol number 1 is behind the counter because it's Schedule 2. Whereas all the other ones, T2 to T4, are safe. That's where they are stored. Okay? So I want you guys to look at the previous slide that I explained the different drugs and the different controlled substances. Can you tell me which one of these is a narcotic or a straight narcotic? So a narcotic drug or a straight narcotic. T4, excellent. T4. So can you tell me why T4 is a straight narcotic? There you go. That's perfect. Exactly. Because it has, so this is straight narc. And the reason why is because it has one narcotic compound and one non-narcotic compound. So one narcotic, codeine, non-narcotic, acetaminophen. Okay? Perfect. You guys got it. That's absolutely perfect. Okay, I'm glad. So then, can you tell me Tylenol number 2 and Tylenol number 3, what do they classify as? Narcotic preparation. Excellent. And can you tell me why they are narcotic preparations? Perfect. Because they have two non-narcotics. So they have caffeine, they have Tylenol, and they have one narcotic, which is codeine. Excellent, guys. Very, very good. I'm glad you got this. Okay. So can you tell me then, Tylenol number 1, what classification is that? Exempted. Excellent. Okay. That's amazing. I'm very glad. And guys, why is this exempted prep code exempted under the exempted category? Eight milligrams. There you go. Perfect. You guys were listening. Great. I'm glad. Okay. So someone is asking, why is Tylenol 4 a straight narcotic? Because it has only one non-narcotic ingredient. So if we go back here, okay, and it's a narcotic with less than 2 other non-narcotic ingredients. So less than 2 would mean 1, right? So if it's 1 non-narcotic and 1 narcotic, which is codeine, that would make it a narcotic drug, or what we call a straight narcotic. Does that make sense? Okay, you're welcome, Mohammed. No problem. So it would be like a narcotic drug. So sorry if I made it a little confusing. I see a comment here. So there is narcotic drug, like it'll fall under the drug, and then it'll fall under a straight narcotic. So straight narcotic would mean like there's, for example, codeine only. Of course, it's not 8 milligrams of codeine, okay? But products, it could be a narcotic, that'll be a straight narc. If it's a narcotic drug, if it falls under the narcotic drug, then it can be a product with less than other non-narcotic ingredients, okay? On the exam, I don't think they'll like make it very tricky for you. They'll tell you, like, when with the options, they're not going to tell you, like, they won't make it tricky for you. They'll give you like one word as opposed to multiple meanings. You know what I mean? So okay. Okay, so when it comes to looking at how we use narcotics in practice, okay? So in practice, we may get prescriptions over as a verbal, so the doctor calls us and we write the prescription down, or they may fax it to us, okay? They may give us, and like say, I'll give the patient 30 tablets and then I'll give a refill. So a refill meaning if I'm giving the patient a quantity of 30, okay, on the prescription, and then they tell you refill for R, refill 1, that means they qualify for 30 tablets plus another 30 next time. So refill 1 is another fill of the 30. So that would make total quantity 60. Does that make sense? That's what a refill means. So doctors can have that, okay? Some doctors may say, I want a refill on the prescription. Sometimes we may have the prescription at one pharmacy and then the patient wants to pick it up at another pharmacy. So that's where transfer comes into play. So that means if we can transfer out the prescription. So there's rules about this. We can't just do this all the time for all the drugs. Now remember, in COVID times, these rules changed. And even now, and during COVID, these rules have been changed but temporarily. So on your exam, they will tell you whether it's COVID time or not. Most of the time, again, you can look at this with your coordinator, with Fatima. I don't believe they're going to test you on this about COVID, because with COVID, there's COVID exemptions and they have allowed for transfers. They've allowed for a lot of stuff. So I don't think the exam is going to test on that. I think they'll just test on these rules. But you can also ask Fatima about this, just to be sure. Okay? So when it comes to narcotic drugs, so this is without COVID. Okay? This is without COVID exemptions. When it comes to narcotic drugs, they can be written. So the doctor writes a prescription and the patient brings us that prescription, or they can be faxed. The doctor cannot call it in verbally, and the doctor cannot put refills on it, and you cannot transfer this out. Okay, that's pre-COVID. Narcotic preparations, you can accept them as written, as faxed, or as verbal. So we can get a verbal from the doctor. Okay? Controlled substances, part 1, you can do everything. So we can get it as written, as faxed, as verbal. However, we can also get it as a refill. We can get it as a refill, but there is a restriction. You can only give a refill if the medication was written or faxed. Okay? Not verbal. Okay? Only if it's written or faxed, I can give a refill for controlled substances part 1. So this is part 1. I can only give a refill if there is something called an interval between the refills. So what is an interval? So I'm going to delete this part. I want to show you guys what an interval is. So for controlled substances, so for part 1 of controlled substances, or even like an interval is needed for all controlled substances, I should say. All parts. Okay? An interval is the following. So what this means is, let's say I have a prescription. Doctor says, Concerta, which is methylphenidate. Concerta 36 milligrams, okay. Quantity 30. Refill 2. This is not allowed like this. This is not a valid prescription. We can give only 30, but we ignore the refills because it's not allowed. We need an interval. So if the doctor writes, dispense 30 tablets every 30 days, this is an interval. So an interval is a time that the doctor writes so that a refill is valid. Okay, so I give an interval of when I can dispense my medication. So that what this means is, Concerta 36 milligram, I can give 30 tablets every 30 days. If the patient comes at day 29, I cannot give it out. Why? Because the doctor said, they put a restriction. You give 30 tablets every 30 days. Not every 29 days, every 30 days. This would be an interval. So controlled substances require an interval. The only difference is that part 1, you can get refills only for written or faxed. Whereas for part 2 and part 3, again, you can get written, faxed, verbal, refill. You can add refills as well as an interval, regardless if it is written, faxed, or verbal. Does that make sense, guys? Do you see the difference? The difference between part 1 and part 2 and 3. So part 1 is more restricted. So if it's written, faxed, and there's a refill, and with an interval, I can accept that. If it's verbal for part 1, with a refill, I can't accept that. Okay? Part 2 and part 3, I can accept refill with an interval, with written, faxed, or verbal. Okay? Someone's asking, for part 1, can we take a verbal without refill? We can, yeah. It's not a problem. Someone's asking, is there a maximum allowable refill for controlled substances? Jody Ann is asking. There is no really, like, the doctor's going to put that restriction. So they'll say, give 30 tablets only every 30 days. You can't give more than 30 tablets. It's a restriction that the doctor wrote. So we can't go against that. Sometimes though, if the patient is going on vacation, then the doctor will say, dispense 100 tablets or whatever. Or we can dispense it early than the interval. Only in that case is when the patient is traveling, so the doctor plays around with it. So Jigar is saying, controlled substances require interval for refill no matter the part. Exactly, you got it. If it's part 1, part 2, part 3, needs interval. Interval needed. Okay? Needs an interval for controlled substances. So part 1 would be amphetamine methylphenidate. Okay? Part 2, we said, would be the anabolic, so testosterones. Part 3 would be your barbiturates. You're welcome, no problem. If you can clear your question, please, if I answered it. Just so I can answer more questions. Okay? And then finally, targeted substances. You can get it as written, as faxed, as a refill. However, you can only refill the targeted substances, such as benzodiazepines, if it's been less than 1 year since the prescription issue date. So if let's say the doctor writes the prescription on March 20 of 2023, okay? You can only dispense it up until 2024, March 20. And then it becomes inactive. And then you cannot, even if there's more refills, we cannot dispense it because it's been more than 1 year. So if it's only valid for 1 year and that's it. And then when it comes to transfers, with benzos, that's the only thing that can get transferred out, and you can only transfer it once out. Whereas all the other ones, you cannot transfer out. Okay? So let me go ahead and answer some questions. I know this gets a little confusing. You need to do practice questions in order for this to really stick in your head, okay? Okay. So, to answer some questions about this particular slide, here I'm seeing some comments. I have Abija is saying, can you repeat the part about transfers? Because I have seen methadone transfers that the patient goes for vacation or away for a few days, so they couldn't take it from their regular pharmacy. Yes, this is what I'm saying about the COVID exemptions as well. So sometimes transfers, you'll see them even for narcotic drugs, and that's because of the COVID exemptions. Okay? So I hope that makes sense. There is COVID exemptions that don't follow this at all. So you may see that in practice. Mandeep is asking, what does transfer mean? Transfer means you're giving the prescription away to another pharmacy. So we transfer it out from the computer to another pharmacy. Okay? So again, please clear your questions if I answered them. So Ugo Chukwu, sorry if I'm not pronouncing your name properly, it's valid for up to 1 year. Okay, so 1 year. So you just have to remember that it's only good for 1 year. Okay. So like I know it says less than 1 year for the benzos or the targeted substances. On the exam, they're not going to like give you such a time of when it's close to 1 year. Like they'll make it very obvious. They'll make it 2 years. They'll make it 3 years. On the exam, it's not going to be like very vague. It'll be very straightforward. Okay. So again, some doctors can give intervals for narcotics. That's fine. You can give intervals with anything you want. Any medication, you can give an interval. That's not a problem. But as a requirement for regulations, you have to have intervals for controlled substances. Part 1, Part 2, Part 3 have to have an interval if you're giving a refill. You have to. Otherwise, you can't accept the refills. Everything else, okay, you can't even have refills to begin with. But if you do have refills, then you have to give an interval. Does that make sense, guys? So you can give an interval for anything. Mahsa saying, does tramadol need to be kept in the safe? Yes, it does. Yeah. Queen Frida is saying, all other controlled substances except targeted don't have an expiry date. So here's the thing. This is a big topic. It's a big debate. So if you get someone, we said you can only dispense targeted substances if if the prescription is less than a year old. Okay. The other ones technically don't have that requirement. So you can technically dispense it after 1 year, everything else. So everything, all of these. However, as a pharmacist, you have to use your professional judgment. You can't be dispensing a narcotic that was given. Let's say a patient comes and gave you a prescription for a knee replacement surgery and was prescribed narcotic. They come 2 years after and they tell you, can I fill that narcotic? You'll be like, why? Like, what are you using it for? And then they'll tell you, oh, I was prescribed this for surgery 2 years ago. Okay, that was 2 years ago. What are you using it now for, right? So you have to use your professional judgment. You can't just dispense it just because it has no expiry, right? You're welcome, Queen Frida, no problem. So please, again, guys, please clear your questions so I can answer most of the questions. Prachi, that's what I was mentioning. You have to ask Fatima about this because, to my knowledge, they said they weren't going to test on COVID-19 exemptions. However, just double check with Fatima about this in case there's new changes that came out, okay? So I would know this very, very well and then let Fatima know about this. I personally don't think they're going to test on COVID exemptions. They're going to test on this instead. But to be on the safe side, just double check with Fatima so she can get you the most updated answer, okay? Okay. You're welcome. No problem, guys. Okay. All right. So there's lots of great questions, but let's move on with the lecture and then maybe I can answer them towards the ending. So does that make sense? So I just want to quickly do a recap for you guys again. So narcotic drugs, we can have written, faxed, no verbal, no refill, no transfer. Okay? Narcotic preparations, we can have written, faxed, and verbal. That's the difference. You can do verbal with narcotic preparations. Controlled substances, part 1, I can do written, verbal, fax, refill, but the refill can only be on the written and fax. I can't do verbal refill. Okay? And I have to have an interval. Whereas part 2, part 3, I can get written, fax, verbal, and refill. And I can even get a refill on the verbal as well. But of course, I need an interval. Targeted, I can do pretty much everything except for fill refills that are less than or more than 1 year old from the prescription date, and I can only transfer it out once. Okay? All right. Storage. When it comes to fridge storage of drug products, we have something called the cold chain. So cold chain is a temperature-controlled supply chain for products such as pharmaceuticals, vaccines, blood products that may need specific temperature range during distribution and storage. So you have to keep these separate from other non-drug items, so separate from foods in the fridge. Vaccines need to be put between 2 to 8 degrees Celsius with an alarm thermometer to tell us if, let's say, there is the fridge goes to 10 degrees. So that means that the fridge is no longer between 2 to 8. And that means the vaccines have to be looked at in case there's an issue with the storage, because we said it has gone beyond 8 degrees. That's what the Health Canada recommends, as well as what the governmental public health recommends, to have vaccines between 2 to 8 degrees. Frozen vaccines should be kept between -50 and 15. And when we're looking at the storage, like I said, we always want to take steps to ensure optimal environment from the time that the manufacturer makes the medication to the delivery of the medication to us, so from the distributor, and then to given to the patient and administered to the patient. So we have to make sure that we are keeping it at optimal levels or storage levels as per manufacturer. Okay, so it's the whole chain. That's why it's called cold chain. So it goes from manufacturer, okay, to distributor, to pharmacy, and then to patient, right? So all of this, it has to be kept in the proper temperature. If, let's say, this is not kept in the proper temperature and a break in the cold chain occurs, when the storage of the vaccines falls outside the recommended temperature range, so I was mentioning if it goes beyond 10 degrees as an example, we have to separate the affected supply, and we call the public health unit or the manufacturer to tell them about this. Because let's say if this happens, then maybe my drug is no longer optimal, and it's no longer okay for us to give it to the patient. Okay? So other things that need to be kept in the fridge would be these antibiotics. So once I reconstitute an antibiotic, or once I add water to it, so I need to keep it in the fridge. Again, which ones? It's only certain antibiotics. Otherwise, if the antibiotic is in a powder form, powder is kept in room temperature. Okay? Only when it's reconstituted, it's kept in the fridge. And which ones? So amoxicillin can be kept either in room temperature or fridge. Okay? But we prefer the fridge for amoxicillin. Amoxiclav has to be kept in the fridge. Azithromycin, it could be either temperature or room temperature or fridge. Clarithromycin should not be kept in the fridge, and it should be kept at room temperature. Cephalexin, fridge. Cloxacillin, fridge. Clindamycin has to be at room temperature. Okay? So this is an example of a monograph, and this is just something so that you guys are aware of what a monograph looks like and where you would find information about storage. So basically, when you look at any monograph, so as an example here, we took Xalatan. So Xalatan is basically eye drops. They're kept in the fridge, okay? And where you look into this information, so how would you know if something needs to be kept in the fridge, is you look up the monograph and then you look under storage and it tells you how to store it. So it tells you before, for example, the eye drops, before Zalatan is opened, keep it in the fridge between 2 to 8 degrees and out of light. They tell you how to store it. Once the bottle gets opened, then you have to keep Zalatan at room temperature, so up to 25 degrees Celsius, and it has to get discarded after 6 weeks of opening the bottle. So this is just an example. You don't necessarily need to know it, but it's just as an example of where you would find storage information. Okay? All right. So let's go through this case. A mother comes to your pharmacy and brings a prescription for her child, Lily, who weighs 18 kilos. The prescription is for amoxicillin clavulanate, okay, with a dose of 75 milligram per kilogram per day of amoxicillin, and is divided 3 times a day, so TID is 3 times a day, for 10 days. Okay? The brand of amoxicillin clavulanate you have available in your pharmacy is Clavulin 400, which has 400 milligrams of amoxicillin and 57 of clavulanate in each 5 mils. Okay? The bottle size is 70 mils. How many mils of clavulin does Lily have to take 3 times a day? And how many reconstituted bottles do we give to Lily? What do you guys think? I'll give you a couple of minutes if you want to work on this. Okay. So, 75 milligram per kilogram per day. Okay. Our child weighs 18 kilos. Good. This gets removed. So what that means is we have 75 times 18. 1,350 milligram per day. We divide this by 3 because it's 3 times a day, which is 450 milligrams per dose. Okay? If I have 400 milligrams of amoxicillin, so we always look at the amoxicillin portion, we ignore the clavulanate portion. 400 milligrams per 5 mils, okay? What if I have 450, right? I need 5.6 mils per dose. So this is per dose. She's taking 3 doses in a day. So that means I need 16.8 mils per day. Okay? If I times that by 10, because it's used for 10 days, means I need 169. So I round it up. 169 mils. I said the size of each bottle is 70 mils. So how many bottles to give? Most of you said 3, and that's correct. The reason why 3 bottles, which would be 210 mils. We always give more than less, because with more, they can always throw away the remaining. Whatever's remaining, they can throw that away. But if we give them less, then they don't have enough for 10 days, right? So we need 3 bottles. This is the bottles to give them. Okay. My question to you is, and I'm going to give you a trick. Here's the thing. I have a question for you guys. If clavulin, so clavulin 400 is stable at room temperature for 7 days, and that's if it's reconstituted. It's stable if it's in the fridge. It's stable for 10 days. So what would you guys do in this case? How many reconstituted bottles would you give her? Exactly. Sorry, I should say this. My apologies. It's good for 7 days only. Sorry, this is amoxicillin. This is just the amoxicillin portion. My apologies about that. It's stable for 7 days in the fridge. Because look at what we said here. Amoxiclav has to be refrigerated. And it's only good stable for 7 days in the fridge. So clavulin has to be refrigerated. So if you reconstitute it, it's only good for 7 days in the fridge. So what would you guys do? So you'd give 2 bottles. How many would you mix and how many would you not mix? What do you guys think? Exactly. So the majority of you said to mix only 2. So you mix only 2, and the third one you give to the patients. So let's calculate this. Let's actually calculate it so that we're all on the same page. So we said each bottle is only good for 7 days in the fridge. Okay? So let me calculate that. I want to calculate to see how many days is each bottle going to last. So I said I need 16.8 mils per day. If each bottle is 70 mils, so 70, divide that by 16.8, how many days is that? Four days. Okay? So does it make sense for me to mix 1 or 2? How many should I mix? Remember, it only is good for 7 days. Each one is good for 4 days. Each bottle is good for 4 days. So I would mix 1 right now, today, mix only 1. And then I would give the remaining water for the mom to mix the other 2. Does that make sense, guys? Or I could tell the mom, listen, I can keep the other 2 here, and then you can come in 2 days, and then I can mix it for you so that it's as fresh as possible, because it has to be kept in the fridge. Exactly. Wellen said, just 1, because the second one will be expired the last day. Exactly. That's what I was trying to get at. This is a trick question. Okay, guys? So I hope this made sense. If it didn't make too much sense, then what I would do is rewind the video and then go from there, okay? So unfortunately, guys, I can't repeat too much because we still have another lecture to go, okay? So rewind the video and watch the video, and then go from there. If you still don't understand it, then you can ask questions on the WhatsApp group, okay? All right. Okay, the dispensing process. So dispensing process looks at prescribing, transcribing, dispensing, administering, and monitoring. So when you're prescribing, it's the healthcare practitioner giving the prescription. So it's a doctor, a vet, a dentist, or a nurse practitioner can do it, a midwife, a podiatrist, or even a pharmacist. If in some provinces, some pharmacists can now prescribe. So you can have, as I mentioned, handwritten or printed or faxed or even e-prescribed prescriptions. So e-prescribed would be like prescribed online through a system, and then we get it as an online prescription. Okay? You can, and also has to have an image of a signature to make sure that this is legit, that this is a prescription that we can take. It has to have the date, and it has to be partially pre-printed. So what that means is some things like doctor might like pre-print as like a template. So sometimes some doctors may have a template that they like, and they can pre-print some stuff on them. So like their address, their signature, their name, things like that. It's already pre-printed. And then you want to look at identifying fake prescriptions. So fake prescriptions would be if, let's say you look at a narcotic as an example, and the narcotic has as a quantity like 500 tablets. That's a lot of tablets. What are you going to do with that tablets? Like you have to question that as a pharmacist. This is way too many tablets. So you have to see if this is fake prescription or legit prescription. You also have to, when you're taking a verbal, you can take a verbal from a physician's secretary. However, the secretary has to give you her name, and she has to give you the doctor's license, because ultimately it will go under the doctor's name and license. Okay? So look at this prescription. Can this prescription be filled as written? Look at it. There's oxycodone 20 milligram IR tablets. There's a refill on it. There's the name of the patient. There's the doctor's number, name and license number. So why exactly? Some people are saying there's no ID. No ID. So you require an ID such as a health card number or driver's license for narcotics. That's a rule. You need that. Okay? Another indication is you look here, ND. Is this a real doctor? It's a naturopath. So not all doctors can prescribe for narcotics. Okay? So you have to look to see if NDs exactly, they cannot prescribe. So that's another thing. Let's look at here. Again, this is what I was mentioning before. It's not everybody that can prescribe. So we have, when you look at the rules, there's refills. That's another practitioner or a naturopath doctor. They're not authorized to prescribe narcotics. It's only medical doctors, nurse practitioners, midwives, dentists, and podiatrists that are authorized to prescribe for narcotics. Okay? Let's look at a prescription hard copy. So when we say a prescription hard copy, this is an example of a prescription in community pharmacy, and this is in Ontario, using a system called Kroll on the computer. So it prints out basically the pharmacy information here, name, address, phone number, the patient information here, their address, their date of birth. Here it looks like at the drug information, so it tells you the name of the drug, the quantity, how to take the medication. And then over here, it gives you the prescriber's information. Okay? This is where the pharmacist would sign the hard copy. So hard copy, this is for systems that are more, I guess, older systems that actually have paper. A lot of pharmacies now are paperless, but you still see this in some pharmacies. Okay? So dispensing. When it comes to common errors, you can have verbal errors versus written errors. So verbal errors, let's say if the doctor calls in a prescription, they can be very fast calling in a prescription, or they may have an accent and you don't understand what they're saying. They may have like very busy or noisy environments in the background. They may tell you something like 15 versus 50. So this is really hard to tell when you're listening to this over the phone. You may have sound-alike medications as well. Okay, so medications that sound similar. Or you may have similar same patient name. Or even closed-ended questions. So this is very hard for verbal, or it can very easily cause a verbal error. Written errors would be doctors writing very badly, illegible. They might write OD and OD, so either once daily or or if you're looking at the context of the eye, so that's where things can be different. Lookalike medications such as Toradol and Tramadol, incorrect patient, or even poor fax quality, so how the picture looks like. Okay. When we're looking also at dispensing, we have to look at interchangeability. So interchangeability looks at an ingredient that has the same quantity of active ingredient. Okay, so as an example, I can have pantoprazole as an example versus Sandoz or Mar pantoprazole. Okay, so these are interchangeable. We call these interchangeable as an example because they have the same quantity of active ingredient. They have the same pharmacokinetics or comparable pharmacokinetics. They have the same route of administration, so tablet, same dosing schedule, and the price does not exceed the brand name version. That's when we can say these are interchangeable. Okay? When it comes to generic products, they're basically the same chemical ingredient. They work the same way, same mechanism of action. They're just cheaper. They're like the cheaper form. So they're the cheaper form of the brand name. So you might say, when should we then use the brand name instead? If the patient says, I want brand name. So brand name is the, let's say the parent drug company made it. Okay, this is the original drug company. Okay, so an example of brand name would be Tecta. Tecta is the brand name of pantoprazole. Again, pantoprazole magnesium. So there's pantoprazole magnesium, pantoprazole sodium. This is Tecta pantoprazole magnesium salt. So if the patient requests brand name, so let's say the patient says, I want Tecta, or if there is no stock of the generic version, or if the doctor writes on the prescription, do not substitute, that means you have to give the brand name, because either the patient wants it as brand name, there's no generic form of this, okay? And there is a do not substitute. The doctor wants the patient to be on the brand name. Then you have to dispense the brand name. Otherwise, you dispense generic. Okay? So if a new pharmacy is faxed over to the pharmacy for a new patient, would you fill it as a brand name or generic, assuming that the person is not answering the phone? So you'd always give generic if you can't get a hold of the patient. If the doctor, again, did not write no sub or do not substitute, then you have to give it as generic. Okay? The next stage of dispensing is when we're filling or checking. So we fill the prescription or we package the prescription. So we put the label on the product, okay? We do a technical check. So we want to see if the medication that's put in the vial or the medication that's being given out has the correct patient, the drug dose, form, the prescriber, the quantity, the number of refills. And this can be performed by either pharmacist, registered tech, okay, even a pharmacy student, or an intern, okay? These have to be under pharmacist supervision because they don't have a license yet. Registered pharmacy tech has a license. So when it comes to blister pack preparation, any pharmacy staff can make blister packs. So blister packs are these packs that are divided up into morning, so AM, into noon, into evening, and into nighttime. And you put each medication in the right timing so that patients can take that pack, and instead of taking it as a vial, taking the medication as a vial, so that they remember easily. So anybody can prepare a blister pack, but the final check has to be completed by a registered pharmacist or a registered tech. Okay? When it comes to clinical check, this can only be done by pharmacists or even like a pharmacy student or an intern if they're like if they have a rotation. So right here. And clinical check looks at the therapeutic appropriateness of the medication. So is this the right dose? Is this the right drug? Things like that. Okay. And we also take into consideration the counseling portion, which is part of the clinical aspect. So here, this is a little chart to tell you what each pharmacy staff member does. So pharmacists can do pretty much everything. Everything a pharmacist is allowed. Registered techs can receive new prescriptions and repeat verbal prescriptions, except for controlled substances. So registered techs can take any verbal except for controlled. They can perform independent technical prescription checks. They can accept or send transfers. They can perform tests on the tissue, so below the dermis. They can also administer vaccines now, but only publicly funded vaccines. When they accept or send transfers, they cannot send or accept benzos or targeted substances. That's the difference between a registered tech. They also cannot prescribe for minor ailments or smoking cessations, things like that. Registered pharmacy student or intern can do everything. Pharmacy assistant can't do any of this. Okay? Okay. Here we're looking at expiry. So the expiry looks at the differences. There's two definitions that I want to highlight. So expiry and beyond use date. So expiry looks at the day after which the drug is no longer stable or does not meet therapeutic requirements. So this, you'll see this on the bottles of the prescription, on the stock bottle. Beyond use date looks at the date after which the medication has been repackaged or manipulated. So this looks more at compounds. Okay? So compounds are also governed by NAPRA, and we follow these guidelines. So if I have a non-aqueous formulation, so non-aqueous formulation, so non-water containing formulations, the beyond use date is no later than the time remaining until the earliest expiry date of any active ingredient, or 6 months, whichever is earlier. So if I mix two ingredients and each of them says an expiry of December 2025, so that's 1 year from now, if I mix them together, I have to either have the earliest expiry date of any active ingredient or 6 months, whichever is earlier. So I would do 6 months because that is earlier than 2025. That would be my beyond use date. For water containing oral formulation, so this is oral to take in, it's no later than 14 days. At controlled cold temperatures. So 14 days is the beyond use date. No later than 14 days. Water containing now, this is no longer oral. Now it's topical, dermal, mucosal, liquid, or semi-solid formulations is 30 days. So no later than 30 days. Okay? So this is now talking about recall. I don't know if you guys remember, I was mentioning recalls in the beginning of the lecture. And recalls are divided up into 3 classes. Class 1, Class 2, Class 3. Class 1 is the most serious because it can cause health consequences or death. Okay, so this is when you receive a pharmaceutical company letter regarding a medication that they want to be removed off the shelf. So class 1 is the worst. It can cause serious health consequences. Class 2, it may cause acute health effects. So it's not as bad as class 1. And then class 3, it's unlikely to cause harm. Okay? These are the different classes of recalls. Okay. So here we have 6 cases. Let's quickly go through them and then take a quick break before we start the new lecture. So case number 1 here. This is basically talking about a 25-year-old male who comes to your pharmacy and says, I have an expired EpiPen at home that's going to expire next month. He heard that EpiPens are currently not available, so they're on back order. What would you tell WQ in this case? What do you guys think? Excuse me. Sorry. Okay, so you guys have great answers. You can, let's say the medication has expired and I'm having a very bad reaction, anaphylactic reaction. If I don't have medication, if I don't have any medication anywhere, okay, then that's worse than having to use an expired product, right? So if my product is expired and I can't breathe, I would much rather use that product that I have as opposed to not use anything at all, right? Because the medication's on back order, so there's nothing we can do. We can't get it from any other pharmacy. We can fax the doctor for an alternative, okay, but let's say if all the alternatives are gone, there's no other alternative, then all you have to do is you tell the patient to check the actual window here. So if the window is not clear, if it has like little particles in it, that means it's not good to use. If it's clear, if it's okay, you don't see any little particles in it, then technically you can use it to save a life. Okay? Does that make sense, guys? And of course, we always have to call 911. Exactly. Question number 2, or case number 2. I have a registered pharmacy technician who answers the phone at the outpatient clinic, and the patient is calling, or the physician is calling for a prescription verbal for venlafaxine and clonazepam. Can the registered pharmacy tech accept both prescriptions as a verbal? What do you guys think? Which one can they accept and which one not? Exactly. They can only accept venlafaxine, okay, not clonazepam. Okay? Okay. Case 3. Patient comes into your outpatient clinic asking for help to take a blood pressure reading. Can the registered pharmacy technician do this? So yes, exactly, yes. They can do this. They can show them the machine, okay? They can perform this. However, if the patient asks and says, can you tell me if this number is good? Is it high or is it low? Registered pharmacy tech cannot do that. They have to call the pharmacist at that point because only the pharmacist can interpret the number. Exactly. They can check, but they can't counsel. Navjot is saying. That's perfect. Yes, exactly, guys. You got it. Case 4. You're a pharmacy manager at a community pharmacy that is part of a family health team. It has been brought to your attention that some of the oral hydrocodone medications are expired. What would you do for narcotic expiry? So basically, with narcotics that are expired, you have to remove them from the shelf, right? From the shelf. Because you can't use them. You do not need a prior authorization for narcotic destruction. This was before, a couple years ago, we had to send a letter to Health Canada and then they had to approve it and then we were able to destroy our narcotics. We don't have to do that anymore. So now we just go straight into destroying the narcotics. So what we do is we mix the narcotics with like some soap and we just kind of shake it very well to make sure that the medication can no longer be used. That's basically what we need. Okay, so a pharmacist can do this. However, there has to be a witness. So witnesses can be like anyone who has a license. So like it would be like a registered tech or 2 pharmacists, things like that. Okay? Case 5, you're a pharmacy manager at a community pharmacy that is part of a family health team.
How often should physical counts and reconciliation of all narcotics controlled substances be conducted? So how often should you guys measure your or count your narcotics? Okay, so I'm getting different answers, but it's every 6 months minimum. At my pharmacy, we do it every week. Every week we're doing it at my pharmacy, but legally you have to do it every 6 months. Not only every 6 months, also when there's a new manager. So let's say there's a change in leadership, so change in manager, then you have to do that. Okay? Or when there is a theft. So if a theft took place, then that's when you would do it. Okay? Case 6. You're a pharmacy manager at a community pharmacy that is part of the family health team. It's brought to your attention that the theft of oxycodone products took place last night. What is the best course of action to take? What do you guys think? Exactly. So Gurpreet is saying to report to Health Canada. Perfect. Most of you are saying that. So you have to report this within 10 days. Okay? That's the requirement. So it's within 10 days of the event, you have to report this to the ministry. Okay?